Hello again. Welcome back. Today we'll continue our discussion on respiratory disorders, diagnosis, management, and prevention. We will be discussing chronic obstructive pulmonary disease, otherwise known as COPD. Chronic obstructive pulmonary disease is a group of disorders characterized by chronic inflammatory lung diseases that causes obstructive airflow from the lungs. Symptoms include breathing difficulty, cough, sputum production, and wheezing. It is typically caused by long-term exposure to irritating gases or particulate matter, most often from cigarette smoke. People with COPD are at increased risk of developing heart disease, lung cancer, and a variety of other conditions. It is marked by a decrease in FEV1 or 1 second forced expiratory volume and an increase in FVC or forced vital capacity with an increase in FEV1 FVC ratio. Emphysema and chronic bronchitis are the two most common conditions that contribute to COPD. They usually occur together and can vary in severity among individuals with COPD. Chronic bronchitis is inflammation of the lining of the bronchial tubes which carry air to and from the alveoli of the lungs. It's characterized by daily cough and sputum production. Emphysema is a condition in which the alveoli at the end of the bronchioles are destroyed as a result of damaging exposure to cigarette smoke and other irritating gases and particulate matter. Although COPD is a progressive disease that gets worse over time, COPD is treatable. With proper management, most people with COPD can achieve good symptom control and quality of life, as well as reduced risk of other associated conditions. What are the characteristics of chronic bronchitis? It is clinically defined as a productive cough occurring during at least 3 consecutive months over at least 2 consecutive years. It is linked to cigarette smoking, also to air pollution, infection, and genetic factors. There is hypersecretion of mucus due to hyperplasia of mucus-secreting submucous glands. It presents with productive cough, dyspnea, hypoxia, cyanosis, and weight gain. Complications include cor pulmonale, recurrent infections, and even lung cancer. Now, what are the characteristics of emphysema? They are dilatations of air spaces with destruction of alveolar walls and loss of elastic recoil. They are strongly linked to cigarette smoking. Its characteristics include 1. An increased antero-posterior diameter of the chest or barrel chest, an increased total vital capacity, hypoxia, cyanosis, respiratory acidosis, weight loss, and pursing of lips and use of accessory muscles of respiration. There are 4 different types of emphysema. First is centrilobular emphysema, which is characterized by dilation of respiratory bronchioles. They are often localized to the upper part of the lung. Second is panacinar emphysema, characterized by dilation of the entire acinus, including alveoli, alveolar ducts, respiratory, and terminal bronchioles. They are uniformly distributed throughout the lung with loss of elasticity. They are genetically determined loss of alpha-1 antitrypsin, an alpha-1 protease inhibitor. Third are paraseptal emphysema. They are characterized by dilations involving distal part of the acinus, including alveoli and the alveolar ducts. They are localized subjacent to the pleura and interlobar septa and associated with large subpleural plebs or bullae that may rupture and cause pneumothorax. And lastly are irregular emphysema. There is irregular involvement of a sinus with scarring within the walls of the enlarged airspace. They are complications of various inflammatory processes. What is the pathophysiology of COPD? 1. Air travels down the trachea and into the lungs via the bronchi. Inside the lungs, bronchi branches many times into bronchioles that end in alveoli. The alveoli have very thin walls full of capillaries. The oxygen from inspired air passes into these capillaries to enter the bloodstream. At the same time, carbon dioxide is exhaled. The lungs rely on the natural elasticity of the bronchial tubes and alveoli to force air out during expiration. In COPD, there is a loss of elasticity and overexpansion, trapping air in the alveolar sacs post-expiration. Cigarette smoking attracts neutrophils and macrophages, which produce elastase that destroys elastin in the lung tissue and inactivates alpha-1 antitrypsin. Let's discuss the symptoms of COPD. COPD symptoms often don't appear until significant lung damage has occurred, and they usually worsen over time, particularly if smoking exposure continues. They include the following: 1. Dyspnea, or shortness of breath, especially during physical activities. 2. Is wheezing. 3. Is chest tightness. 4. Is chronic cough that may produce mucus or sputum that may be clear, white, yellow, or greenish. 5. Frequent respiratory infections. 6. There is lack of energy. 7. There is unintended weight loss in later stages. And 8. Swelling in the ankle, feet, or legs. People with COPD are also likely to experience episodes called exacerbations, during which their symptoms become worse than the usual day-to-day variations and persist for at least several days. Now, what are the causes of COPD? The main cause of COPD in developed countries is tobacco smoking. In the developing world, COPD often occurs in people exposed to fumes from burning fuel for cooking and heating in poorly ventilated homes. Only some chronic smokers develop clinically apparent COPD, although many smokers with long smoking history may develop reduced lung function. Some smokers develop less common lung conditions. This may be misdiagnosed as having COPD until a more thorough evaluation is performed. Different causes of airway obstruction include the following: 1. Emphysema. This lung disease causes destruction of the fragile walls and elastic fibers of the alveoli. Small airways collapse during exhalation, impairing airflow out of the lungs. 2. Is chronic bronchitis. In this condition, the bronchial tubes become inflamed and narrowed, and the lungs produce more mucus, which can further block the narrowed tubes. Chronic cough develops due to clearing of airways. Another cause is cigarette smoke and other irritants. In the vast majority of people with COPD, the lung damage that leads to COPD is caused by long-term cigarette smoking, but there are likely other factors at play in the development of COPD, such as a genetic susceptibility to the disease, because not all smokers develop COPD. Other irritants can cause COPD, including cigar smoke, secondhand smoke, pipe smoke, air pollution, and workplace exposure to dust, smoke, or fumes. And lastly, in about 1% of people with COPD, the disease results from a genetic disorder that causes low levels of a protein called alpha-1 antitrypsin. Alpha-1 antitrypsin is made in the liver and secreted into the bloodstream to help protect the lungs. Alpha-1 antitrypsin deficiency can cause liver disease, lung disease, or both. For adults with COPD related to antitrypsin deficiency, alpha-1 antitrypsin deficiency treatment options include those used for people with more common types of COPD. In addition, some people can be treated by replacing the missing alpha-1 antitrypsin protein, which may prevent further damage to the lungs. Let's go to risk factors. First is exposure to tobacco smoke. The most significant risk factors for COPD is long-term cigarette smoking. The higher the pack years, the greater the risk. This includes secondhand smoke. Second, people with asthma. Asthma increases risk for developing COPD. The combination of asthma and smoking increases the risk even more. Third is occupational exposure to dust and chemicals which can irritate and inflame the lungs. Fourth is exposure to fumes from burning fuel, mostly in the developing world. People exposed to fumes from burning fuel for cooking and heating in poorly ventilated homes. And lastly, genetics. The uncommon genetic disorder, alpha-1 antitrypsin deficiency, is the cause of some cases of COPD. Other genetic factors likely make certain smokers more susceptible to the disease. Now, what are the different complications of COPD? First are respiratory infections. People with COPD are more likely to catch colds, the flu, and pneumonia and could cause further damage to the lung tissues. Second is pneumothorax due to rupture of subpleural blebs. Third is interstitial emphysema with air escaping into the interstitial tissue from a tear in the airways. Fourth are heart problems. COPD can increase the risk of heart disease, including heart attacks. Fifth is lung cancer. People with COPD have a higher risk of developing lung cancer. Sixth is pulmonary hypertension, which is high blood pressure in the lung arteries. And lastly, depression. Difficulty breathing can limit pleasurable activities, and dealing with serious illness can contribute to the development of depression. How do we prevent COPD? First, quitting smoking to help reduce risk of heart disease and lung cancer. Second, get an annual flu vaccination and regular vaccination against pneumococcal pneumonia to reduce risk or prevent some infections. And lastly, avoid occupational exposure to chemical fumes and dust. How is COPD diagnosed? COPD is commonly misdiagnosed. Many people who have COPD may not be diagnosed until the disease is advanced. The most important is medical history, especially smoking and physical exam. Laboratory tests ordered may include the following. 1. Lung or pulmonary function test. They measure the amount of air that can be inhaled and exhaled, whether the lungs deliver enough oxygen to the blood. Tests include spirometer, measurement of lung volume and diffusing capacity, 6-minute walk test, and pulse oximetry. Second is chest X-ray. The chest X-ray can show emphysema and can rule out other lung problems or heart failure. Third, CT scan. A CT scan of the lungs can help detect emphysema and help determine if surgery is beneficial. It can also be used to screen for lung cancer. And lastly, arterial blood gas analysis measures efficiency of the lungs in oxygenating and removing carbon dioxide from the blood. Laboratory tests may be used to determine the cause of symptoms or rule out other conditions like alpha-1 antitrypsin deficiency. How is COPD treated? Well, many people have mild forms of the disease for which little therapy is needed other than smoking cessation. Even for more advanced stages of the disease, effective therapy is available that can control symptoms, slow progression, reduce the risk of complications and exacerbations, and improve the ability to lead an active life. The most essential step in any treatment plan for COPD is to quit all smoking. Stopping smoking can keep COPD from getting worse, but quitting smoking isn't easy. Now, medications for COPD includes the following. First are bronchodilators. Bronchodilators relax the muscles around the airways. They can help relieve coughing and shortness of breath and make breathing easier. They usually come in inhalers. Examples of short-acting bronchodilators include the following. 1. Albuterol. 2. Ipratropium. 3. Levalbuterol. Now, examples of long-acting bronchodilators includes the following. 1. Aclidinium. 2. Arformoterol. 3. Formoterol. 4. Indacaterol. 5. Tiotropium. 6. Salmeterol. And 7. Umeclidinium. Inhaled steroids can reduce airway inflammation and help prevent exacerbations. Side effects may include bruising, oral infections, and hoarseness. They are useful for people with frequent exacerbations of COPD. They include fluticasone and budesonide. Next are combination inhalers. Some medication combine bronchodilators and inhaled steroids. They include 1. Fluticasone and bilanterol. 2. Fluticasone, umeclidinium, and bilanterol. 3. Formoterol and budesonide. And 4. Salmeterol and fluticasone. Next are combination inhalers that include more than one type of bronchodilators. Examples include 1. Aclidinium and formoterol. 2. Albuterol and ipratropium. 3. Formoterol and glycopyrrolate. 4. Glycopyrrolate and indacaterol. 5. isolodaterol, and tiotropium. And lastly, umeclidinium and vilanterol. Next is oral steroids. For people who experience moderate or severe acute exacerbation, short courses, for example, 5 days of oral corticosteroids, may prevent further worsening of COPD. However, long-term use of these medications can have serious side effects such as weight gain, diabetes, osteoporosis, cataracts, and an increased risk of infection. Next is phosphodiesterase 4 inhibitors. Roflumilast, a phosphodiesterase 4 inhibitor, is approved for people with severe COPD and symptoms of chronic bronchitis. It decreases airway inflammation and relaxes the airways. Common side effects include diarrhea and weight loss. Next is theophylline, a less expensive medication which may help improve breathing and prevent episodes of worsening COPD. Side effects are dose-related and may include nausea, headache, fast heartbeat, tremor. So, blood levels of the medication should be monitored. And lastly, antibiotics. Respiratory infections such as acute bronchitis, pneumonia, and influenza can aggravate COPD symptoms. Antibiotics help treat episodes of worsening COPD, but they aren't generally recommended for prevention. Azithromycin may prevent episodes of worsening COPD, but side effects and antibiotic resistance may limit their use. Other treatments include lung therapies for people with moderate or severe COPD. They include 1. Oxygen therapy. Some patients may need supplemental oxygen. Some people with COPD use oxygen only during activities or while sleeping. Others use oxygen all the time. Oxygen therapy can improve the quality of life and is the only COPD therapy proved to extend life. The second is pulmonary rehabilitation program, which combine education, exercise, training, nutrition advice, and counseling. They may reduce readmission to the hospital, increase ability to participate in everyday activities, and improve quality of life. Other treatment also includes in-home non-invasive ventilation therapy. Non-invasive ventilation therapy machine with a mask helps to improve breathing and decrease retention of carbon dioxide or hypercapnia that may lead to acute respiratory failure and hospitalization. Now, how do you manage exacerbations? Acute exacerbations occur when symptoms become worse for days or weeks. It may lead to lung failure without prompt treatment. Exacerbations may be caused by respiratory infection, air pollution, or other inflammation. During exacerbations, additional medications, such as antibiotics, steroids, or both, supplemental oxygen, or hospital admission may be needed. What about surgical treatment? Surgery is an option for some people with some forms of severe emphysema who aren't helped sufficiently by medications alone. Surgical options include the following. 1. Lung volume reduction surgery. Small wedges of damaged lung tissue are removed from the upper lungs. This creates extra space in the chest cavity so that the remaining healthier lung tissue can expand and the diaphragm can work more efficiently. In some people, this can improve quality of life and prolong survival. Second is lung transplant. Lung transplant can improve patients' ability to breathe and to be active. However, it's a major operation with significant risk like organ rejection and lifelong immune-suppressing medications. Lastly, bulectomy. Bullae form in the lungs when the alveoli are destroyed. This bullae can become very large and cause breathing problems. They can be removed. Lastly, let's discuss lifestyle modifications. They include 1. Controlled breathing. Talk to respiratory therapists about techniques for breathing more efficiently. Also learn breathing position, energy conservation techniques, and relaxation techniques for dyspnea. Second, clear the airways. With COPD, mucus tends to collect in air passages and can be difficult to clear. Controlled coughing, proper hydration, and using a humidifier may help. Third, exercise regularly. Regular exercise can improve overall strength and endurance and strengthen respiratory muscles. Fourth, eat healthy foods. A healthy diet can help maintain strength. If underweight, take nutritional supplements. If overweight, losing weight can significantly help breathing, especially during times of exertion. And lastly, avoid smoke and air pollution. In addition to quitting smoking, it's important to avoid places where others smoke. Secondhand smoke may contribute to further lung damage. Other types of air pollution also can irritate the lungs. This ends our discussion on chronic obstructive pulmonary disease or COPD. See you next time when we discuss the different restrictive lung diseases.